Okay, it looks like it's top of the hour. Thank you everyone for joining us today for our webinar. Just a few announcements before we get started. You can submit your questions via the chat function throughout the webinar, and we'll try to get to those at the end. Certificates for the U.S. attendees will be available on Friday by logging into your account and downloading those there. And stay tuned at the end of the webinar for an exciting announcement regarding a symposium coming later this year. Barbara, if you'd like to go ahead and get started, go right ahead.
Great. Hello, everyone. My name is Barbara Hazy. I'm an assistant and professor of nursing at the University of Wisconsin-Milwaukee. I'm also a certified pediatric nurse practitioner, and I'm a lactation consultant. I have extensive experience working with term, preterm, and medically fragile breastfeeding families. And my research and publications involve pre and post test weighting of breastfeeding infants, composition of mother's milk, and also publications on supply and sustaining supply. So I have no conflicts of interest to report. So we're discussing today the test weighing of premature and medically fragile infants. And the objectives, we're going to be looking at an overview of the past and current state of the science of pre and post test weighing, specifically of breastfeeding premature and medically fragile infants. I'll go through the barriers and facilitators of the technique, review the steps of the test weighing technique. I'll go through some clinical pearls and recommendations, and I'll present a few case studies on the implementation of test weighing into practice. So in a brief history of test weighing, test weighing was actually first addressed in the literature in the late 1800s by Pierre Baudin, who's considered the father of neonatology, as a method to estimate breast milk intake for quality control in his wet nurse clinic. Then moving on to the literature that we have access to is researchers used mechanical and spring balance scales in the 60s and 70s, but there was consistent concern in those decades about the accuracy of the scale to do test weighing. So moving on to the mid-1980s to 1990s, Arthur, Hartman, and Smith did a really nice study on the pre and post test weighting of mothers, and then also doing it with infants. They found that the measurement of milk intake of breastfeeding infants by using maternal weighing, that consistently overestimated the amount that the baby consumed. So in the mid-1980s to 1990s, came the development of the newer electronic digital scale. There were publications by Druitt, Woolridge, Meyer, Engstrom, Kavanaugh, and colleagues, and there were those studies in the mid-1980s to 1990s. In the 2000s, we did our work on the development and testing of a test weighing technique. And in 2015, Rankin and colleagues replicated the technique. And I'll be discussing our study and the validation study later. So moving on to barriers and facilitators of the use of test weighing to assess milk intake at the breast in the hospital setting. First question, can premature and medically fragile infants safely breastfeed? So in the work in the 1980s and 1990s of this group of scientists, studies demonstrated that premature infants are more physiologically stable when breastfeeding versus bottle feeding, and they consume smaller amounts. So Lucas, Smith, and Gebhardt in 2015 did a review of literature on this topic and looked at the studies that looked at the safety of breastfeeding premature infants. They found that premature infants maintain physiologic status during breastfeeding as early as 27 to 28 weeks post-conceptual age. And breastfeeding versus bottle feeding demonstrated a minimal variability in O2 sats and also in heart rate. Preterm infants in studies exposed to breastfeeding at less than 30 weeks that were provided skin to skin and transitioning to breastfeeding techniques and progressed to nutritive breastfeeding sooner. So in around 2006 to 2007, we had the privilege of working with Dr. Paula Meyer at Rush Children's, where she demonstrated that infants less than 1,000 grams, often with CPAP, sucked non-nutritively during gavage feedings. Just a second, I'm getting, oh, sorry. I thought it was getting a text about the webinar. Anyway, moving on, nutritive sucking at the breast and looking at the signs of readiness. When is a baby ready to do nutritive feeding at the breast? So developmental readiness to feed in Lau, Beer, Meyer, and colleagues all demonstrate that many infants at 30 weeks are capable of coordinating suck, swallow, and breathing with the partially emptied breast. We instruct mothers to pump until the breast is empty of milk, then 2 to 3 minutes longer, and then sometimes use partial breast emptying depending on where the infant is at developmentally. Most infants at 32 to 33 weeks may breastfeed without prior breast emptying. So what is the influence of test weighing on breastfeeding premature infants? In 2010, Funkquist and colleagues, and I believe this group of colleagues is the primary scientists are in Sweden, and they compared two groups. They did a test weighing group and a non-test weighing group. The test weighing group achieved full oral feedings at an early postmenstrual age than the non-test weighing group. And the test weighing group was discharged about 1 week sooner than the non-test weighing group. 97 to 98% exclusive breastfeeding happened in both groups. So test weighing group exclusively breastfed earlier. This group of scientists concluded that test weighing provided critical intake information to providers to wean infant from supplemental feedings, earlier attainment of exclusive breastfeeding, and earlier discharge. The non-test weight group may have been gavage larger amounts than they needed, and the mothers in the study expressed confidence in the test weight group with their technique and their breastfeeding skills. So moving on to the next question that comes up around test weighing. Does pre and post test weighing affect maternal confidence, competence, and maternal stress levels? In 2004, Hurst, Meyer, and colleagues, their aim of their study was to determine the perception of the measurement technique, maternal reactions, and feeding outcomes. And they used a test weight and non-test weight group, and mothers were randomized. In the test weight group, all the mothers reported that that technique was helpful to them. 67% indicated they were not at all nervous with the technique, and 33% somewhat. But there were no reports of increased stress or lower achievement with breastfeeding. The non-test weight group expressed concern over the infant getting enough to eat at the breast. And 75% of the non-test weight group said that they felt the test weighing would have been helpful. So confidence levels, moving back to the Funkquist study, they found that the mothers expressed increased confidence in the test weighing group. And in another study done by Hall, Shearer, and colleagues in 2002, their aim was to see how test weighing preterm infants affected maternal confidence and competence. They did a longitudinal repeated measures control group randomly assigned study to test weight and non-test weight groups. Their results were that there were no significant difference in maternal confidence and competence at 4 points of measurement between groups. There was they checked at initial, 3 days after initiation of breastfeeding, at discharge, and 4 weeks post-discharge. In the test weight group, they reported increased competence in breastfeeding their preterm infant versus the non-test weight group over the time points, from points 1 to 4. There's no difference between groups in maternal confidence from points 1 to 4 over time. And there was a significant increase in confidence over time in both groups. So moving on to the next question. and it's an important question, is that can we use clinical indices to estimate milk intake? Essentially, can we watch the feed and look at the infant, looking at certain clinical indicators, and estimate from that the amount of breast milk the baby got? So clinical indicator examples including counting of swallows, time spent at the breast actively feeding, whether that baby has a non-nutritive versus a nutritive sucking pattern, and whether or not there was a change in breast fullness, whether the breast was softening after the feed. Assessment of maternal letdown or infant satiety. So after all these years, I've come to the conclusion that we absolutely need both. We absolutely have to look at the observational data, the qualitative aspects of the feed, maternal-infant interaction, but we also need to have an accurate assessment of what the baby took at the breast. So I bring up the work of Dr. Thori, Shaker, Pridham, Patos, Park, and Fuller, because they have an excellent scale that they use called early infant feeding assessment, skills assessment. And if you want to learn anything about the quality and assessment of a feed, this is an excellent resource for that. But clinical indicator examples so moving on to the clinical indices versus test weighing, that's the question at hand. Meyer, Engstrom, Fleming, Streeter, and Levegne in 1996 did a study on estimating milk intake of hospitalized infants who breastfeed. They used the SMART Model 2 Olympic scale, and they described the accuracy of clinical indices to estimate breast milk intake of preterm infants versus test weighing. What they found in that study is that clinical indices do not provide an accurate estimate of milk intake. Random differences both over and underestimated the actual intake, and they concluded that clinical indicators cannot replace test weighing when accurate supplementation is required. So in a more recent study by Altutas and Kozak and colleagues in 2015, their aim was to detect breast milk intake in preterm and term infants to assess if the infant consumed sufficient volume at a breastfeeding session using the latch score versus test weighing. 75% of the term infants consumed 97% of the expected volume at each session, and 2% of the preterm infants consumed the expected volume. So what that's telling us is that the latch score was not sensitive for preterm infants, and it's actually the latch score is validated for term infants. But it was a very interesting study nonetheless. But in each group, the latch scores of 7 or greater did indicate that 50% or more of the expected volume was achieved. But again, this study found, as in other studies have found, that there was a high variability of intake in each group. Their conclusion was that the latch score cannot substitute for pre and post test weighing to estimate breast milk intake. So in a study published last year, Perella and Nancaro and colleagues published a study on estimates of preterm infants' breastfeeding volumes. And they said that they tested the premature infant breastfeeding tool and test weighing. In this particular study, they studied 60 breastfeeding diets with over 1,186 breastfeeding sessions. They found that the PBAT, the premature breastfeeding assessment tool, was accurate in assessing when no breast milk was transferred, but not when assessing 50 to 100% of estimated volume transferred. Again, as in other studies have demonstrated, there was a wide variability of breast milk transferred. When it was transferred, it was 11 to 47 mLs. 20% of the time, the preterm infants didn't transfer milk at all, according to their test weight data. So moving on to, is test weighing an accurate procedure to measure breast milk intake at the breast? So this is our study. I credit the wonderful work of my colleagues, Jean Barrera, Pamela Murphy, Martina Mueller, a statistician, and Jean Rhodes. And we worked together to put this study together and develop the technique. So what we did, our first step was to identify variables that impact accuracy of test weighing for preterm and high-risk hospitalized breastfed infants, and to test the accuracy of that technique. So our methods were, the technique was developed testing the accuracy of our scales. And keep in mind, we did this in between 2007 and 2008. So the scales that we tested were what we had available to us at that time. The Olympic Smart Scale, Scaletronics, and Medela Baby Weight Scale. We found that we were consistently getting the most accurate weights from the Medela Baby Weight Scale, and the second phase of the study was used with that scale. So we did careful observation of why we were getting inaccurate readings. And that included positioning the infant on the scale. Interesting finding for us on the flatbed scale is that we would lay a bottle of water across the scale, and that same bottle of water would increase 10 grams as it moved across the scale. So we had to put tape on the flatbed scale to keep the baby at the exact same space on the scale and not move the baby back and forth. So that's, so we were challenged by that at that time. Also positioning of lead wires. The baby's movement on the scale was affecting accuracy. The positioning of the scale at the bedside affected the accuracy as well. And the blanket and clothing and our leads dragging off the scale was really led to inaccurate and spurious results. So we had 4 experienced IBCLCs that performed our developed technique with the most accurate scale at the time, the Medela Baby Weight Scale. But we were blinded to infant feeding volume, and we test the accuracy with either bottle or gavage fed infants, and the babies were fed by experienced NICU nurses. So we did infants without leads and infants with leads connected. So I will show you that technique in as we move forward in this presentation. So to assess the accuracy of the pre-weight and the post-weight, we weighed each baby twice. And our clinically acceptable difference between the volume consumed and the actual test weight was plus or minus 5 grams. So just when we did those pre-weights to see that we were having accurate readings, that we were getting those really tight pre and post-weight readings, without leads connected, 20 pairs of weights obtained on 10 infants without the leads. We had absolutely 17 identical weights, and 2 pairs differed by 2 grams and 1 by 4 grams. With the leads connected, of the 24 pairs, 20 pairs were absolutely identical, 3 differed by 2 grams and 1 again by 4 grams. So our results were, after we tested our developed technique, and again, we were assessing blinded, we did the test weighing, we were blinded, the weigher was blinded to the amount consumed by gavage or bottle. So we knew that the nurse knew exactly what the amount was that was consumed by the infant. So with 95% confidence, this test weighing technique that we developed demonstrated an accuracy within 5 grams of actual volume consumed. And we also concluded that test weights must be performed with a consistent technique and evidence-based methods to control for variables that lead to inconsistent and inaccurate readings. So I'm going to play a 4-minute video for all of you. And this is our test weight video.
Accurately measuring infant milk intake during breastfeeding is important in the management of preterm and other hospitalized infants. This video will demonstrate a pre- and post-test weight technique for hospitalized breastfed infants. This method will assist you in achieving the most accurate results for infants with or without leads. Weigh the infant exactly the same without any changes before and after the breastfeeding. Do not change the diaper or add or subtract anything between weights. If possible, disconnect the leads. Ensure the scale is on a flat surface and that it is level. Position the cart so that it is right up against and touching the crib or isolette. Suspend the monitor alarm during the test weight. Disconnect the leads. While still in the crib or isolette, bundle the infant tightly. To minimize movement on the scale, press the on zero button and wait until the zero appears. Place the infant on the scale. Be sure the leads or anything else are not touching the edge of the scale. The pre-weight will register and the lock arrow will beep. Remove the infant from the scale. Press the weight entry button to program before weight into the memory. Leave the scale on while breastfeeding. Reconnect the leads and breastfeed the infant. After breastfeeding, suspend the alarm, disconnect the leads, rebundle the infant, press the on zero button, wait until the zero appears. Place the infant on the scale. Value displayed is the after weight. Once the after weight has registered, remove the infant from the scale. Press and hold weight gain button to display the milk intake value. Document this accordingly. When the infant must remain connected to the leads or other tubing, begin by placing the scale in the off position to allow time to prepare infant and leads for test weights. Place the infant on the scale. Be sure the infant is bundled tightly to avoid movement. Tape the lead connection point and any other tubing to a flat surface on the crib or isolette. Lift the infant and press the on zero button and wait until the zero appears. Place the infant on the scale. Be sure the infant's extremities or the blanket are not touching the edge of the scale. The scale will beep when the weight registers. Be sure there is no tension pulling on the leads. The wires of the leads must not touch the scale. Remove the infant from the scale. Leave a piece of tape in place on the crib during breastfeeding. Record the weight on the infant's chart. Breastfeed the infant. Turn the scale off while breastfeeding. After breastfeeding, return the infant to the scale. Be sure the infant is bundled tightly to avoid movement. Retape the lead connection point and any other tubing at the same point used for the before weight. Be sure there is no tension pulling on the leads. The wires of the leads must not touch the scale. Lift the infant, press the on zero button, and wait until the zero appears. Place the infant on the scale. Scale will beep when the after weight registers. Calculate the weight gain and record it. What not to do when using a proper pre and post weight technique. Loose bundling of the infant can lead to infant movement. Blankets or clothes touching the edge of the scale. Changes between pre and post weight. Hats, blankets, pacifiers, or changing the diapers. Touching the edge of scale or tension on the leads, as well as holding them at different levels, will contribute to inaccurate readings.
Okay. And moving on from our work in that publication, Rankin and colleagues in 2016 validated this technique, and they did a single center prospective cohort study with babies 28 to 36 weeks. And they did 3 pre-weight and 3 post-weights obtained using with and without lead techniques. They did 101 test weights performed with 68 infants. Their results were that estimated and actual gavage or bottle-fed volumes highly correlated, p-value less than 0.001, with a mean absolute difference of 2.95 mLs. 85% of their test weights were within the 5 ml of actual feed volume and did not vary by corrected gestational age, feeding duration, or volume, formula versus breast milk, or caloric density. They also reported that adherence to the study protocol was critical, that 89% of the test weighing group were within plus or minus 5 grams, but with non-adherence to the protocol, it's 71% when the methods were not followed. For example, concerns re-securing the leads or issues with the leads technique. So I want to go through some examples of test weighing and why it's important, and we've demonstrated that in our practice. So these are case studies. These are actual infant case studies using test weights, but they tell a story of how test weights were implemented and the decision making that happened thereafter. So Baby Smith was a term gastroscopy infant, and he was intubated and NPO for a month. He was transitioned to the breast. The mother had an excellent milk supply. She had a lot of storage at the time. So while the infant was NPO. So everybody was happy with the quality of the feeding. This baby looked great at the breast, was on the breast for about 30 to 40 minutes. The mother said the baby had a strong latch, but the baby was not gaining weight at all. So we implemented test weights, and we found that this baby was not transferring milk at all. So we got the occupational therapists involved. They did an evaluation. They attempted to bottle feed, and they concluded at the time that the baby didn't have sufficient intraoral pressure to bottle feed. So then the baby, the surgical team placed the G-tube, and the baby was sent home on G-tube feeds. There was other things going on in this case as well, because the mother had a surplus of milk stored at the hospital, but wasn't bringing in milk in the last few weeks. So we weren't quite sure. She said she had a great milk supply, but she wasn't bringing her milk in. So we have to kind of weigh both of those things, like what is the maternal milk supply, assessing the infant and such. So anyway, I call this a cautionary tale of underestimating a medically fragile infant's abilities to feed. So we had a diaphragmatic hernia baby, infant Tyler, who was very ill, very sick baby, and he was intubated for 2 months. When they did his final surgery, they decided to place a G-tube as a backup because he was so critically ill and NPO for so long. So this mother had an abundant milk supply. She was bringing in milk every day in high volumes. And this baby, initially when the baby went to the breast, had oral aversion. So we put the baby skin to skin. We had the baby do some nuzzling. And in a matter of a couple of days, he was beautiful at the breast. And so he did not want bottles after that. And his mother was okay with that. She had exclusively breastfed her other children, and she said, "I'm okay with this." But that was hard on the surgical team, because they weren't sure how much this baby was getting and whether we could safely send this baby home from a nutritional standpoint. So what we did is we initiated test weighing. We saw a beautiful gradual increase in volume at the breast, and the initial discharge plan for this infant was to go home on a continuous G-tube feed at night and breastfeed during the day. But the surgical team and the neonatologists were so happy with the test weight data and the baby's growth and how the baby was gaining weight beautifully. We sent the mother home with a test weight scale, and they didn't touch the G-tube. This baby went on to exclusively breastfeed. I contacted her 6 months later, and she was still exclusively breastfeeding. They took out the G-tube 2 weeks later, and they never used it. So moving on to clinical pearls and recommendations. Now we published our study in 2009, so we have a lot of recommendations. And I consulted with my esteemed colleagues at MUSC. I also have my own recommendations. So these are those. So what you should do in your institution, if you're not already using test weighing and you plan to, is assess nursing and medical staff attitudes toward test weighing in your institution. Get a feeling, get the lay of the land, get an idea of how people are feeling about this, and assess their educational needs of staff and mothers. So you need to teach evidence-based test weighing procedures. So my colleagues have developed at MUSC a lactation to go program where they teach nurses at the bedside in test weighing technique, breastfeeding techniques. And I also encourage you to check the accuracy of your own digital scales in your institution. This is a very easy study to replicate with bottle and NG fed infants, and check the accuracy of your scales. So we have found that engaging and educating mothers to actually do the test weights on their own has been very successful. Mothers are fabulous at this. They really embrace it, they do it. But it is important to still, going back to what I had said earlier, it is still important to closely observe that breastfeeding session and observe for signs of nutritive sucking and audible swallowing. This is important, and sometimes you can hear the audible swallowing. It's quite obvious, or you can take a pediatric stethoscope and listen at the neck for audible swallowing. But you must document and to see that swallowing is occurring before initiating test weights. Because if you initiate test weights too early, that can increase stress level of the mother. So we have found that the disconnected leads procedure is the most accurate procedure consistently across the board. And then it's also important to establish a consistent section in electronic charting for documenting test weight results that guide provider recommended supplementation. So I also want implore people to think about the language and the statements that we're using when we use test weighing and interpret the results. So for example, avoid phrases such as he or she only took 10 mLs this time, or he or she didn't do well with this feeding. Educate the breastfeeding parent in developmentally appropriate stages of feeding and emphasize the positive feeding behaviors and progress. Emphasize that bonding moment and what went on during the feed. You know, there's all sorts of gorgeous things that happen during breastfeeding. You know, the baby touching the breast, or you know, the contentment and the relaxation, and you know, those are the kinds of the positive sort of aspects of the breastfeeding session, and what happened with the interaction of the mother and the infant. So also continuously assess breastfeeding parents' responses to test weighing. If it's too stressful, it may need to be discontinued. You can try again later at another time when the baby's feeding improves, or you can use other methods. But it is important to keep assessing the mother's response to test weighing. So if an infant is not transferring any breast milk, or has feeding difficulties that are followed by feeding specialists, consider non-nutritive sucking at an empty breast during gavage or G-tube feedings. We do this frequently, and a vast majority of the time, mothers just love it. It allows for the baby to be nourished by other means while not nutritively sucking at the breast. Also, pre and post test weighing is an excellent tool in assessment of failure to thrive infants and breastfeeding infants. It's just, we use it many times over. You can assess the cause of failure to thrive. It can be if a baby is transferring milk beautifully, then the pediatric team then can go to organic causes and say it's not related to breastfeeding. Or if it is related to breastfeeding and the baby's not transferring milk well and it's a maternal supply issue or infant sucking issue, those are the things that will guide your plan. So test weighing, I've used it, and also my colleagues have used it many times over as a very great tool to assess and diagnose causes of failure to thrive in breastfeeding infants. So the other thing that's important is to avoid drawing any inferences over a test weight result in a single breastfeeding session. And because going back to the studies that I presented in the beginning of this presentation, there's high levels of variability that can occur at each breastfeeding session. So look at the pattern of infant breast milk transfer over several feedings and look at the progress the baby is having. Continue to look at that bigger picture of what's going on and not focus too heavily and make all sorts of decisions around a single breastfeeding session, especially if a baby didn't transfer much at that feed. So I want to go through also some case studies of how this was implemented into clinical practice. First, we'll go through ours. So we were not using test weights in 2007. We were at the Medical University of South Carolina. We were typically, the method that was being used is they would say 10 minutes at the breast, supplement half the feeding by NG, OG, or bottle. 20 minutes or greater, no supplementation is required. The MDs were writing orders for volume that the baby needed. The nurses were bottle feeding it to assure the accuracy of the volume intake with mothers who desired to breastfeed. We noticed a high amount of maternal dissatisfaction with the fact that they were not breastfeeding when they wanted to breastfeed. Their babies had the breast. Our physicians and nurses were at the time skeptical of the accuracy of the test weights. And at the time, which drove our study, was that there wasn't a lot of information on how to get these accurate results. So our neonatology team at the Medical University of South Carolina has a wonderful, head by our director of neonatology, has a wonderful evidence-based and values committee. It's an interdisciplinary committee where practice changes are reviewed and approved. So we took our study and results to the Evidence and Value Committee, and they passed it into practice with our data, with the demonstration of our data and the purpose as well. So we trained 20 breastfeeding team leaders in the technique, who subsequently went on to educate the nursing staff in the test weight technique. We presented at staff meetings on all shifts, and we did new staff trainings. We incorporated test weighing into biannual competencies on all units, and all staff were checked off on the procedure. So again, I'm just going to breeze through these slides so you can kind of see again the technique, how important it is to have the scale flat and level, the disconnection of the leads versus the keeping the leads connected procedures are slightly different as was demonstrated in the video. The baby should be clothed. The infant should be bundled to minimize infant movement on the scale, and weigh the baby exactly the same without any changes before and after. No changes at all. Don't add anything, don't change diapers, nothing. It's just a difference between the pre and the post weight. The weight needs to be done immediately after the breastfeeding session and not delayed. So this is just a mother performing a test weight procedure on her infant. The disconnected leads procedure. This is a little premature infant, and you can see where he needed a nipple shield, this particular infant did. Always assess for pooling in the nipple shield tip, check for audible swallowing, and then once the baby's feed is done, do that post-weight. So moving on to just a few more implementation of test weighing into clinical practice. Giuliano, Pekalski, and Walsh in 2019 did an implementation of pre and post test weights to enhance direct breastfeeding in their neonatal intensive care unit. They used our test weight video. They educated the staff in the knowledge and increased their confidence and knowledge in the test weighing technique. When they surveyed the nurses, they found that 5.26 considered it a barrier to breastfeeding, 29% said sometimes, 42% reported never. 81% of the nursing sample reported that the evidence-based consistent test weighing technique was critical to accuracy. Then Gregory in 2018 did a use of test weights for breastfeeding infants with congenital heart disease in a transitional care unit. And this was a best practice implementation project. They wanted to increase the total number of direct breastfeeding sessions in their PCICU. They tackled the fears of breastfeeding and the inability to quantify volume consumed, which prevented the providers from accurately supplementing infants. They identified that as the biggest concern for not putting babies to the breast in this population of babies. So the baseline rates of direct breastfeeding sessions range from none to 7%, and they educated 84% of their staff on the test weighing procedure. The number of direct breastfeeding sessions, something popped up on my screen. The number of direct breastfeeding sessions rose to 90% of mothers who chose to breastfeed at the breast. And mothers expressed increased confidence in breastfeeding, and the implementation project had a positive impact on the breastfeeding culture of the unit. So those are 3 case study examples of NICU and a PCICU implementing test weights into the institution. So does anyone, are there any questions, comments, discussion?
Thank you, Barbara, for that great information. Does look like we have about 20 minutes for questions and answers that we can go through. Just a reminder, submit those questions you have through the chat function, and we'll try to get to those that are coming in. The first question, Barbara, that came in is, this is in regards to the video shown. The Medela baby weight scale has a memory function for weights. If after weighing pre-feeding and the scale is turned off and then turned on prior to post-feeding weight, does it keep the pre-weight in memory while it is off?
You know, that is a good question, and we have that in our original. This is what I would advise, because they have a newer scale model. So somebody familiar with that scale, you know, with that memory function may be able to add it. One of the things that we were doing by turning off the scale, and I have to emphasize this, is we share scales. We clean them and move them between infants sometimes. So that's why I've always instructed families to put that pre-weight in on a card and then get the post-weight later in case we had to test weight another baby within the unit. So excellent question. And I'm wondering, Kim, if you could ask that question of somebody at Medela. Because I don't know if you turn the scale off, if it keeps it in their memory. But that's an excellent question.
Yes, Barbara, I will definitely go ahead and weigh in on that on this end with the product manager for the Baby Weight 2 scale to see if the new one offers that. And I will get back to Lydia, who asked that question. So I will send the answer via email.
And in
sure.
I'm sorry, Kim. In many cases, we would leave the scale on and use that memory function if we know that we didn't need to use the scale in the meantime with another infant. So it's an excellent function. It's wonderful because it calculates the weight. It does, you know, it has that test weighing function in it.
Okay, thank you. I used to be in customer service many years ago in Medela, and I would have remembered that off the top of my head, but since I've been removed from that department and in education now, I don't have the current product information, so unfortunately I can't answer that. But like I said, I will get the definite response to that question and get that out. Someone did make a comment, and I'm not sure if this is the new Baby Weight 2 scale or not, but she said we have the Medela scale and it will not keep the weight if you turn it off. But again, I will definitely follow up on that and make sure that we get the right information. But thank you for that. The next scale, or I'm sorry, the next question is Is this technique also recommended for term infants? Obviously, no leads or tubes, but babies are not usually swaddled, so may be moving around quite a bit after or while weighing.
You know, that's another excellent question. And we definitely have used it in older infants. But as a baby grows and gets bigger, it gets a bit increasingly harder. But most of the time, if in the window when we use it in the term population, and of course medically fragile infants, many of them are term as well, but we do attempt to wrap them if they'll allow us, and try to minimize the movement on the scale. But one of the things I encourage you all to do is do that 2-weight method to see how you're doing on that pre-weight and that post-weight. Because that, if you're concerned about it, you can see, you know, how much variability you get between those two pre-weights. But yes, we use it in term. We've used it in term infants for years. There's often we get failure to thrive infants coming in and as, you know, as old as sometimes 6 months, and more often it's recognized in the first few months of life. But it's definitely an important assessment technique.
Okay, thank you for that. The next question is, were the babies in your study skin to skin or wrapped when nursing?
Well, keep in mind that this was a study testing the accuracy of the scales and the accuracy of the test weight procedure. So these babies were not put to the breast. These babies were gavage fed and tube fed, so we knew the exact amount they were getting in, so that we could assess the accuracy. So this technique was developed with a known volume going into the infant. So, but do we use skin to skin and that to promote breastfeeding? Absolutely, we do that all the time. So.
Okay.
And the Rankin study was the same. The validation of the study, they used gavage and bottle-fed infants, because it's essentially a validation of the technique to see if does the test weighting technique measure what the baby took in.
Okay, the next question, okay, here it is. Do you calibrate your scale yourself? And if so, how often?
Well, what we do is, it's my understanding, and this is at the Medical University of South Carolina, is that our biomedical engineering, our department is responsible to calibrate. They do it each year. And if any of my colleagues are online, they may be able to speak to if they do it more often. But it's my understanding, when I worked with biomedical engineering, that they would do it every year. But one of the things that's really important is to make sure the scale is level. Because sometimes we would go and find our scales were on carts, for example, and sometimes we would find them, you know, in equipment rooms and such, and they were slightly off. So we would have to level the scale out. So that's really important.
Okay, the next question is, and this one came in Spanish, so I quickly translated it. How many times a day is it recommended to do test weighing? Is it recommended for all feeds?
Now, that is an excellent question. And my guess is that there's variability in culture of units. So I will share our neonatology team decided that because of the need for fortification and the evidence that was before them to optimize neonatal growth, there was a certain amount of fortified feedings the babies needed to discharge and post-discharge in our preterm population. So they would they were comfortable with babies going to the breast about 3 times a day in addition to fortified breast milk feedings. So if the mother's comfortable and is available and there's 24-hour rooming in available and the mother is comfortable, she can go ahead and test weight her infant when the baby goes to the breast. But what there are also, I know other NICUs, cultures, say in Scandinavia, for example, that may do much more frequent breastfeeding throughout the day. That it's different. It's different from NICU to NICU, for example. But if the mother's comfortable to go ahead and test weigh, you can certainly do it. But what I found is that if I see a pattern established, especially as a baby's getting closer to discharge, I was pretty comfortable with a baby getting test weighed a couple times a day. And then kind of, because the reason I say that is in an ideal world, it would be wonderful for medically fragile and premature infants to go home with a Medela baby weight scale. But so that the mothers can do this themselves. They can say, this is what my baby took in at the breast. This is what I need to supplement either now or later in the day. But that wasn't feasible for us. We had difficulty finding the scales to rent. So we have to there's a certain amount of decisions that you have to make on the information that you have at the point of discharge and the availability of using test weighing at home. And again, in an ideal world, if it was up to me, mothers would have a scale at home and be able to do this at home. And that may be feasible in some communities, but in ours, it wasn't at the time.
Okay, the next question is, do you recommend an inexpensive scale for parents to buy?
That is another, I love the questions today because they're all excellent. I worry about this because we can, it can increase stress levels. And I speak to daily weights. Okay, if you're weighing, it's like an adult stepping on the scale every day. It's going to go up, it's going to go down. It creates a lot of stress. So if a family wants a scale at home, I usually recommend weighing their baby no more than a couple times a week, or whatever their pediatrician wants and recommends, or pediatric provider. So I'm very interested in this question, and I would love to test it now in the age of telemedicine and telelactation. I would love to see if there's affordable scales out there where we can get test weight data in our telelactation visits and encounters. So that's why I encourage all of you, test these scales and use this technique to test your scales. Because if you go online and look for scales, they can range anywhere from $60 all the way up to in the thousands. So that's a very long answer to a short question, but there's a lot more work to be done on this topic in regard to scale accuracy.
And as a side note, purchasing scales, there are scales that are available to rent. So that would be also an option if it's a rental station that has the Baby Weigh 2 scale for rent. So the next question is, I prefer scales that are accurate to 1 gram. Do you feel this helps with accuracy as compared to a scale that weighs to 5 grams accuracy? We use the Olympic at our hospital.
My question to that would be, I would encourage you to do a mini study as we've done and really check it with test weighing. And I bring this up, and this is a bit of an important point. One of the things that comes up in the test weighing studies is the question of insensible water loss and the specific gravity of breast milk. Okay, so this was all considered and reviewed when we did our study, and I'm looking at my notes here. So previous studies described that dressing and wrapping infants prior to weighing was a process of standardizing the clothing and preventing insensible water loss by the cutaneous route. But Woolridge and colleagues found that, or suggested that insensible water loss was insignificant over the course of an individual feeding. Now, fat in human milk can affect volume to milliliters by about 3%. So the correction of this density is considered with insensible water loss. Dr. Paula Meyer and colleagues suggest that that small increase in fat, which increases the specific gravity, that small risk of insensible water loss during the feed, counteracts the small loss from insensible water loss when we test weigh. So I think, at least at this point, that 5 grams of accuracy is good. It's better than guessing. But if we can achieve within 1 gram of accuracy, but we have those insensible water loss, specific gravity of human milk issues, but they're very, very small. So.
Thank you very much for that answer. Looks like we're almost at the top of the hour, so I just want to go over a couple quick things before we end today. Certificates will be available for U.S. attendees by downloading those off your account on Friday. And registration for the July 21st webinar is available and open at medilaeducation.com. And I'm excited to announce that the Medila's 15th first ever virtual Global Breastfeeding and Lactation Symposium that will take place September 21st through the 22nd. Registration will be open for that at the end of the month, and we will be sending out some information for that for everyone that's on the call as soon as that's open. And thank you everyone for joining us today, and enjoy the rest of your afternoon. Thank you, Barbara.
Oh, you're welcome. I hope everyone has a great day.